Good afternoon, and welcome to Exploring IT Optimization Opportunities in the Mid-Revenue Cycle, a health system CIO production sponsored by E4Health. Just a little housekeeping before we get started. My name's Anthony Guerra. I'm the founder and editor-in-chief of Health Systems CIO, and I'll be your moderator today. We're looking forward to your participation. You could send in your questions or comments at any time in the Q&A box, and we'll take them later in the program. Just so you see how we're going to spend our time today, first we're going to go about 35-40 minutes with our main panel discussion featuring Otter Palace, SVP of Clinical and Revenue Cycle Applications with Providence, James Wellman, VP and CIO at Nathan Littauer Hospital and Nursing Home, and Nicholas Raup, SVP for AI and Automation Solutions with E4Health. And then we will have our Q&A. So let's jump right in. Lots of great stuff to talk about today. Otter, you want to start? Give us an overview of your organization and your role.
Sure. Thank you for the introduction. So I'm Otter Palace. As mentioned, I'm the SVP of our clinical and revenue cycle applications here at Providence. We're a West Coast-based organization. We have about 52 hospitals, over 15,000 providers, 2,000 clinics up and down from Alaska to Texas. And so we're a pretty large organization. We have been on Epic, our medical record across the organization, and have standardized all of our revenue cycle operations into a single business office. Appreciate the invite.
All right. Go ahead, please.
No, I'm just thanking you for the invite.
Oh, very good. Thank you, Otter. James.
Yeah, I'm James Wellman. I am the Vice President and CIO at Nathan Littauer Hospital. We are a rural health facility in upstate New York. And we are, like for many of the rural hospitals in today's society, we're trying to figure out how to stay open and keep ahead of the curve of a lot of things that we're doing. So this whole conversation for us is exciting because we feel like some of the technology and AI is the key forward for us. And I think it's really important. So we're looking forward to this.
Excellent. Very good, James. Thank you. Nick?
Yeah, good morning, good afternoon, everyone. E4Health is a technology-enabled services organization that partners with healthcare systems and providers to effectively record their patients' journeys, ensuring the quality and accuracy of that data. My role within E4Health is to lead our innovations team, which is chartered with identifying, building, and implementing technology solutions to augment our services businesses and enable them to drive greater value to our customers in the form of performance and quality improvement. So thank you for having me here today.
All right, very good, Nick. Thank you. All right, Otter, we're going to start with you. Define the mid-revenue cycle. Which processes does it include? What lies outside this portion of revenue cycle?
Sure. So for us, a mid-revenue cycle basically sits between patient access and then the back-end billing. So it includes the clinical documentation processes that determine whether or not we get paid accurately and on time. And so some of those things that are included in the revenue cycle operations is clinical documentation, as I mentioned. So CDM, charge capture and reconciliation, coding, obviously, both the professional of the facility, HCC, et cetera, case management, workflows, utilization management workflows. Order accuracy. So again, how accurate is the actual order compared to the documentation and the medical necessity. Denials. So again, we all have to deal with denials on a daily basis. But what is our prevention workflows associated with that? That's part of that mid-revenue cycle. And then, really things like the clinical to billing translation. And so in Epic speak, that's the Resolute workflows. And then I would say probably quality measures and HCC. So that risk capture has a lot to do with that mid-revenue cycle operations.
There's a lot in there. It's not, there's a lot in there. So lots to talk about today. James, any additional thoughts on what Otter mentioned?
Well, no, because he nailed everything in here that we look at from the scope perspective. I think the key thing we look at this is where we always kind of say the mid-cycle is where the accuracy meets the value. So as we're trying to figure these things out, we'll get into our next sets of questions. it's critical. And I think this deserves a bigger look. And it's always been kind of lumped in RCM in the past, I think, and we need to break that cycle.
Excellent. That's sort of first step is realizing this needs more attention. Nick, your thoughts?
Yeah, I mean, I agree with both Adder and James. I don't know that I would have a lot more to add. I mean, from my experience, MRC includes all those processes and workflows from the point of service or care through discharge to pre-bill, right? And like they both said, there's a lot in there. I think as we really look at our customers and how they're approaching MRC, it's really starting to identify what that cross section is between the traditional workflow and the technology from an AI standpoint that I'm looking forward to talking a little bit more about here today.
All right, very good. Nick, we're going to start with you on this. Why is now a critical time to optimize the mid-revenue cycle, and how can the case be made to prioritize it against competing initiatives such as digital front door, ambient documentation, and cybersecurity?
Yeah, so I think it's a great question. There are obviously the standard reasons why it's critical to optimize MRC, like margin pressure and cash flow challenges, staffing shortages, payer friction. But in my experience, the bottom line is that the medical services being performed are the lifeblood of any provider organization. And if they're not efficient and if they're not accurate, then it doesn't matter how many patients you have waiting at your digital front door. If it isn't documented for all intents and purposes, it didn't happen. And if it isn't documented and coded properly, then your financial model is going to be upside down. So to me, for those reasons, right, it's absolutely critical to optimize those MRC workflows. The one thing that I would say over the past 24 months, right, maybe a little bit longer, cybersecurity is definitely an area where we all need to continue to focus, right, and allocate investment. I think that the unspoken understanding that previously existed around personal medical information being off limits is unfortunately no longer the case. So that is something that I think that is still important. But when we think about MRC and those workflows, those are absolutely critical to our provider organizations from a financial standpoint to be accurate and correct.
Very good. Nick, let's just want to go slightly into something here, and then we'll keep everything going around. You talk about delivering care and getting paid for care are two different things, right? So, I think one of the interesting dynamics here, and you tell me, may be that at some point in this process, you need the actual folks delivering care to do certain documentation things that translate into getting paid. Many of these folks don't think so much about that kind. They think about patient care, they think about patient safety. Getting paid almost feels a little unsavory. Is part of what we need to do here to get the clinicians to understand that in order to keep delivering the care and keep the door open, that documentation has to be tight? Is that part of everything we're going to talk about here?
Absolutely, right. And that's where I kind of go back to if it isn't documented, then it's almost like it didn't happen, right? From a financial standpoint. And so really bringing that transparency and understanding to the providers is a critical component of our customers from an MRC standpoint, right? Making sure that their provider partners understand that and really kind of see that translation from documentation to reimbursement and the potential for lost reimbursement when those things aren't documented accurately is a critical component for sure.
Very good. All right. Let's go to uh, James. What are your thoughts?
So I think Nicholas kind of nailed that up, and we looked at this, like you said, from a a four-pillar approach with the margin, staffing, audit intensity, kind of investment prioritization. But the key for us is we think this has a direct impact. You talk about digital front door and those things are there, but with the mid-cycle, we actually see the things to fund those other things out of these. So we want to get paid for what we're doing. We want to be paid fairly, and we want to make sure that we're getting the most out of that. So we know that the payers are using every means available to scrutinize everything that we have, so we have to be prepared for it on the same side. And kind of what you asked, Nick, in there, I think the key with the providers is, sometimes we can provide them with a prompt as they're looking at different things, and that gives them insight on when they're treating the patient. And so it's for the better outcomes for the patient. And I think that's key as well. I don't want to have people coming back and finding out that the things in the work that we're doing, that they're fighting with their own insurance company. We can help avoid that. So, like I say, in rural health, this is tight. We're the only hospital in the county. So we have to make sure that all that data is ready and for them to go. And I think we can do that from both a clinical care perspective and to get paid for it.
And James, how big of a dynamic in all this is getting the actual folks delivering clinical care to understand why you need the documentation to be tight, and that it, as you mentioned, it's going to fund these other things. We know you care about the patients per se, but we as an organization need you to spend maybe a little more time and focus on this a little more because we're having issues over here. I mean, how much of a part of what you're doing to improve this is getting that messaging up front to the clinical folks?
So it's a really important. So I'm not clinical, and I have to have good data that I'm working with our CMO, CMIO to come back and give them and say, look, here's where we're talking to your peers, and let's have this open line of communication. So when I came in here a little over 2 years ago, that was one of the first things we did. We have a lot of meetings with our providers. I'm at all of their department meetings, all the large meetings, and we now have a voice in there to talk about it. And we give them examples. We obviously redact names, those kinds of things, but we talk about this and said, hey, working through here, we saw $13,000 that we missed on this specific case because of this, and this. Here's what we have to do, excuse me, to go back and make sure this doesn't happen again in the future. This is what funds the next thing we want to go. This is what funds the new radiology input or the MRI that we want to put out there, or the new ultrasound that you're requesting for endocrinology. And when they see that direct improvement, we operate off the three. I think a lot of people do. Is it good for the patient? Does it save time? Does it make money? And you can hit all three of those. It's not like good, fast, cheap, So those are all three of the things that we want to strive for every time we hit the door.
Otter, we're going to go to you, but James, I absolutely love that specific use case instance review of, hey, here's what we missed. Specifically, in this case, we need to do better. So
You
that's
can't be generic with providers. That won't work.
right. Very good. Otter, what are your thoughts on what you're hearing?
Yeah, and I feel like I agree with my colleagues. I think MRC is really an untapped frontier for innovation. I think that we've made significant strides in healthcare, automating a lot of the patient access, the back office claims process, et cetera. But the middle portion, the clinical documentation, integrity, the medical coding, the charge capture, the revenue integrity, still often relies on that, on manual, labor intensive workflows. And so in the way I view it is that it's not an if or other. This is a something that is not a nice to have. This is required. So this type of optimization is certainly something that we need to really focus on. But it can't be. So in talking with the clinical teams, they're already overwhelmed, right? So optimizing charge capture, fixing documentation, looking at coding that reduces rework, those types of things, clarifications, they're already overwhelmed. So how do we complement the work that they're doing, the digital front door, the ambient listening? How do we use some of the technology that's available today with AI to help complement that work, not just simply say, hey, we're going to need to sit down there and have you spend more time reviewing your documentation, et cetera. So really looking forward to this area and this the opportunities that it presents to really use some of today's technology.
Otter, let me follow up with you with a change management question. This comes up in all kinds of areas where people are trying to be innovative, and perhaps introduce new tools and perhaps introduce new workflows that those tools will work best with. You have this dynamic of a group of people that are overwhelmed, need help, something needs to change. And even though the change is going to get them to a better place. The last thing they can handle when they're overwhelmed is change. So how do you do that thoughtfully? How do you right retrain or approach people with new workflows when they can't handle anything else?
Right. I mean, the easiest thing to do is don't force change on them. Include them as part of that change. Make them champions of that change. I'm not clinical either, and so it is would not be appropriate for me to go into clinical teams and start telling them, here's how to improve your workflow. Here are things for you to do, when I've never walked a day in their life at all. And so the idea is to bring folks who we are going to be asking to change their workflow and include them as part of that process. Help them define what is a more efficient workflow. What are the things that you want to see? What are the endpoints that you want to be able to articulate and see with this technology, as opposed to, hey, I'm going to sit there in my little lab and come up with what I think is the best workflow, and then I'm going to thrust that change upon you. Change is hard. Humans don't react well to change most of the time. So how do you be more inclusive in that change, as opposed to just forcing that change on people?
That's a great point. And Nick, this again brings me back to, what Otter said makes total sense. Get them involved, get them to embrace it. You still have to convince them of the why, right? And you still have to tie that improved documentation to improved billing to improved patient care, because that's ultimately what they care about.
Yeah, no, absolutely. I think Otter, hit the nail on the head in regards to people not liking change, right? I think that buy-in piece, right, is a big component. What we've seen with customers is that showing them the value, right, giving them a tangible example, like James was talking about, in regards to seeing how this, whatever this change is going to be, is going to benefit them. Getting that buy-in, helping them to really help drive that process is a critical piece, right? The business stakeholders are the subject matter experts, right? Like Otter was saying, like from a technology standpoint, I'll do the hat trick, right? I'm not clinical either, but I think where we can show the benefit of where the technology is going to help make their lives easier, help make their lives better. That's where we really start to get the buy-in. You get those kind of change agents who are excited about the benefit that they can and their teams can see and receive from these improvements in their workflow from a technical perspective. And then it's just a snowball, right? I mean, we've seen multiple instances where kind of say, well, just try this, right? Is this, this little thing that we're going to change here, do you see benefit? And then it's like, well, Pandora's box opens. Well, can the technology do this? Can it do that, right? They start to get excited, and then it just grows on itself.
Very good, James. Let's bring you in here. So I'm not clinical either, but I'm married to one. So something there, maybe a little street cred. Anyway, James, I'm picturing this triangle again. This is a triangle that it will come up many times in your work. You representing IT, clinicians, and then you, in this case, revenue cycle management professionals. You mentioned meetings. I'm imagining all three of those corners of the triangle at the table. Maybe some meetings with just IT and revenue cycle professionals, but eventually you're going to, I assume, have operational leaders in there with all three of those components represented. Is that when you really get the most productive conversations and meetings, when you have all three represented?
Yeah, absolutely. And I think one of the keys here is that's a top-down component. Our CEO, one of the things I really admire about him, and one of the reasons I opted to come here, was when he was showing me how he was presenting this. And we talk about finance and budget in real world terms to everybody in the organization, whether you're the greeter in the front door or whether you're working as one of our neurosurgeons. So we're trying to show the real world conversation with that and how this all applies and how we can help them and how they benefit each other. And when they see that and when they start engaging, then they start, I think Nicholas has cut, they start seeing things like, well, wait a minute, can you do this for me? Yeah, we can do that. Can you get this information to me? Yes, we can. Suddenly it's timely They also figured out that, hey, my work RVUs just went up. I'm getting home a little bit sooner. I don't have the same pajama time. I'm not doing things at home. I got more family time. So it's a win in that regard. So when they get involved, it's critical. If they're not involved, it's a lot harder. So you have to work on that culture change, and you need strong leaders. So that's a key component. We feel like we're poised and heading in the right direction with that. But you don't want to make decisions ever for one of the other groups without their involvement. That's never going to work, and I don't want to be a part of that. So we can talk about things that we're enhancing specifically, directly with clinical, directly with finance. But when we talk about this as a whole, everybody needs to be in the room.
Very good. When we're going to talk a little bit about job role changes and how technology can affect that. And let me start with you, James. I'm guessing that when we get down to that nitty-gritty in this discussion, it's going to be more of the revenue cycle leaders dealing with the people on their team. And the dynamic I'm thinking about is the dynamic of AI that we mentioned, AI and other technologies, assuming some of the low-level work that people have been doing. We all see that from afar and from a top-down view as, oh, isn't that great? But I think there's a human nature element of this that we should just go over, which is if people have been doing a lot of low level stuff as their core job, not all of them are excited to no longer have that particular thing to do because that's what they've always done. And now you're telling them you don't have to do this anymore. And they say, well, this is what I do. And what do I do now? Everybody, we think, oh, they're going to be so excited to do more exciting things and interesting things. When the rubber meets the road, I wonder if that's not always the case. So, James, a little bit more on the tools that can remove some of these things and how to approach that, either from IT, but also, again, the revenue cycle folks in this area are probably going to be the ones deciding on whose work changes.
Yeah. Well, you nailed something that we've always done it this way. I don't know if it'll come through, but there we go. I wear that to a meeting sometimes. It says, we don't always want to do it that way. So we go back, but you have to respect these people and come in. So that's a key component. We baseline with them and we ask them where we can help them, how we can make them more efficient. We also have to come in and talk to them. I'm not looking to get rid of these people. AI to us is a force multiplier. So it's helping us do different things. And I think that's critical. But it's also kind of daunting because there's so many changes out there and so much that we can do. So when we started getting them involved from the beginning, and we had representation when we started this conversation with our patient financial group, we obviously talked with the leadership first. And so we want to introduce this. Our suggestion was to bring everybody in on the front line all the way through each section. And we walked through that and kind of did the workflows and said, where do you run into problems? And then we started looking, how can we bring this in here? So far, because of that approach, we've had a lot more buy-in. The other challenge is some of those things, like you said, are so mundane that it's hard keeping people in that role. They lose interest. They don't want to do the same thing over and over and over. There are some people that like that, and so they become our checkers, and they'll keep checking that as we keep going forward with the AI. But the other one is we're replacing empty positions. So that also helps us and with the funding and the things that we look at this from a perspective. And we do not have a huge pool of people to pull from where we live. We're 45 minutes away from Albany and Saratoga Springs, but like I say, it's the only health system in our county. I do not have a dearth of talent sitting out there that can come in and help us with these financial components. So they're realizing this strength in them, and we talk about it because we've talked about that finance component from the CEO down to them. They recognize that their livelihood and the future of this hospital is critical, and that they are playing a role in there.
James, just to be clear, you mentioned replacing empty positions. Am I to understand that you're not replacing empty positions? You're using technology to fill those roles.
Let me clarify that. We will be using technology, so something as simple as a prior authorization, rather than somebody sitting on a phone or waiting, AI can do a prior authorization component for that and track a lot of those things for us. It can do the summaries. It can go in and check the payer websites when they make one of their midnight changes. And we suddenly get a whole host of denials on something that had not been denied before. So that's a lot of mundane work that we can turn over to technology.
And Otter, this is a really interesting trend, right? We're not talking about a lot. We're not talking a lot about layoffs, but we are talking a lot about not replacing positions that come open until we, and I saw there was a CEO quoted, I saw 6 months ago, there was a CEO quoted as saying, you are required in his company, he was saying you are required to show that AI cannot do the job that's become open before we let you fill it. So the world is changing very fast. But your thoughts on what you've heard?
Yeah, I mean, I agree a lot with what James said. Is that at Providence, there is a lot of additional work that's coming from payers and others that we want to be able to free up caregivers' times for those mundane tasks, for those repetitive tasks that they're doing today, to be able to allow them to do some of the tougher stuff, things that AI just isn't there yet. They may never get to that point, but things that are automating clinical summarizations instead of having somebody coder having to go through an entire medical record to review that medical record, instead just summarize it for the coder so that they can do and produce more than having to sift through something. Because to James's point, I don't believe many people want to continue doing that. I think they do want to do the higher level. They want to feel like they're making a bigger impact. They are tackling the tougher challenges. And so, yeah, I mean, I think it definitely at Providence Technology, we understand technology doesn't drive outcomes. It's engaging all of these folks as part of utilizing that technology, whether it's coder, the clinician, et cetera, getting their feedback and then making those additional changes to be able to take advantage and utilize it. AI is a tool. It's a tool to help them do their job. It's to replace some of those burnout tasks that they're doing so that they can do that higher level work.
Otter, did you say that additional work is coming from the payers?
They're using AI, right?
Yeah.
So the payers are all using AI too. So they're finding all kinds of ways to deny things, et cetera. And so what's coming back isn't just a simple denial; it's a lot more complex. And so we've got to be able to reciprocate and be able to free up the resources to be able to tackle those bigger problems, those more complex problems. And if they're still doing these manual tasks, these automated that can be automated, they don't have the time to be able to tackle those things. So, somebody I can't remember who at Providence mentions like it's becoming a battle of the bots at this
Yep.
point. So, yeah, I mean, I think it is something that more complex rejections, denials, et cetera, are coming from payers.
It's just wild. It's absolutely wild. It is an arms race. And you can't bring a knife to a gunfight. I think that was from the movie The Untouchables. Don't bring a knife to a gunfight. So don't bring a human to a bot fight. Maybe
Right.
it's just wild. Nick, what are your thoughts?
Yeah, I mean, James and Adder hit a lot of great points there. I think as we look at how we're leveraging technology, there's the desire to upskill, right? For our coders, having them augmented with autonomous coding enables some of those coders to now move more into an audit type role, right? Being able to do that review. When you talk about, I think James highlighted some people kind of like doing that rote those types of tasks. Well, the technology still needs that human in the loop validation, right? So the roles, I think, shift a little bit in regards to incorporating the technology, still giving our teams opportunities, but they're changing, right? And I agree. I think that all of us want to have that trajectory, that career path where we see our continued advancement and a path to being able to get there. And the technology helps to augment that, right? By leveraging the technology, like Adder said, it's a tool. I don't view it as a full replacement of humans, right? I think that humans using AI are going to replace humans that don't use AI. but it's not in the short term. It's not going to be a full replacement of the human. It's really filling those positions that aren't able to be filled by humans right now because of staffing shortages. It's being able to enable our team members to upskill and operate at the top of their licensure. It's giving us an ability to focus on those more complex scenarios as payers upskill their AI game, right? So there's just a lot of different opportunities for our team members to continue to advance and embrace the use of the technology.
Well, I think we're getting to something really interesting here that's been touched on. You mentioned Otter mentioned this, Jane, and Nick, you just used the term payers upskilling their AI game. Um, it sounds like there's a real cautionary message here that should go out to all health systems, especially those rural small health systems living on thin margins. That would you say, Nick, that if you're not doing anything differently right now in your mid-revenue cycle or revenue cycle in the way you do it, your revenue is going to go down simply because of what payers are doing with AI on the other side. And that if you don't step up, your revenue is going to go down because you're going to have more denials, you're going to get more complex requests coming back at you that the humans won't be able to handle fast enough. So this could be existential, meaning if you don't up your revenue cycle game, you could slowly be dying on the vine here.
Yeah, absolutely. I think that as we look at just the kind of the unfortunate contentious relationship between payers and
Yeah.
providers, right? I mean that we're at opposite. We have opposite goals, right? Payers want to minimize what they're paying, providers want to maximize it. So inherently, there's that contention, and payers are not going to, just because it's a rural hospital who doesn't have the resources to focus or engage from an AI standpoint, they're not going to pull any punches, so to speak, right? So yeah, I mean, I think that it truly is a matter of, if you're not able to invest resources from an AI standpoint, find a partner that can help you in that regard, or you are facing an existential threat.
James, what do you think?
Oh, he nailed it, because we looked at this and said, we've got a few years and we're fortunate enough to at least have some money in the bank to invest in this. Without it, you're just, like I said, you're just going to hold off the inevitable. So you're either going to be acquired or you're going to shut down, and you'll start losing services, and it just becomes a self-fulfilling bad prophecy there. So we felt like this was the absolute way to change it and stay competitive and do this. Without it, we're not going to make. We don't have a large group, and I don't want to speak for it. And but Providence, we might be probably a rounding error for them.
Yeah.
We've got to sit there and serve this group and our people that are doing it. And I don't have a department, of people that can sit down and spend the time in this, that are subject matter experts. And I don't have a talent pool to pull from that and do it. So this is critical for us right now. I think the next 3 years are going to be a make or break for a lot of places who are able to make this investment and hold it off.
And James, this sort of definitely helps with prioritization, right? I mean, we know where this has to go. You could put this right up there with, although you talk about cybersecurity, ransomware, yeah, that could be an existential event, but the chances of that are probably quite a bit smaller. This could be number one. I mean, there's no chance this isn't going to happen in terms of getting squeezed. So this could be right up there. Listen, you don't take care of you don't improve your digital front door, people still going to come. They need care. Right. They're going to come. Cybersecurity, again, there's bad things can happen, but the risk may be tiny of a catastrophic event. But this is right up there, is going to happen. There's no guessing. There's no wondering. I don't think there's any way to overestimate the importance of this, James.
No, and it funds everything. Right. So no matter what. So we have to put the money back in to the continuing technologies, because we know the payers are dumping more in a month than we'll put in a year easily. But we still have to, have a fair fight. It's like I said before, I just want to get fairly paid for the work
Right.
that we're doing, and we want to recognize, we want to provide the best care possible for our patients and families. That's the key. But we think this is the major differentiator, and that was how we started approaching this a year ago.
All right, it's been fascinating. Let's go a little bit more into specifics. Nick, let's start with you. Let's say you're making a dashboard, right? And you're trying to figure out, okay, I want to improve this. Let me get a little more specific. What specific, maybe some metrics, like if you were giving someone some free advice here, couple of metrics on your dashboard, what do you want to improve?
Yeah, so I think from my standpoint, it really needs to start off with a solid baseline and understanding of your current performance, right? So
Mm-hmm.
your volumes, your case mix, your performance and productivity, the accuracy of your coders, right? The costs are all metrics that need to be clearly quantified, and understanding kind of where your business sits in those regard. And then you need to really look at, from an optimization standpoint, what can you do in-house versus where do you potentially need to partner, right? Do you have existing resources that can focus on this, or do you need to partner from a human capital or even a technology standpoint?
Mm-hmm.
And then it's really looking at, as far as those outcomes are concerned, what's aligned with your kind of your business imperatives, right? Where do you feel like focusing on key areas are going to provide the greatest return and that are aligned with your strategic goals, right? And so, when I think about quality, the turnaround times, performance, cost, all of those are critical metrics that you need to have on those dashboards. And then really that return on investment, like James was talking about, like it's funding these reinvestments of technology. The AI piece can sometimes be a little bit difficult to have a quantifiable return on what that investment looks like, right? So really being clear on what is the desired outcome, how is the technology helping you to achieve that desired outcome, to be able to measure that return, right? That investment versus return equation.
Otter, what are your thoughts?
Yeah, I mean, I think MRC has the greatest leverage is to prevent denials downstream, right? And so, I think if I were looking at a dashboard or to give some advice to folks, I mean, I would be looking at, um, you know, objectives or things that help you reduce that preventable, denial. So first pass yield, denial, looking at your denial rate, both total and your avoidable denial rate, your discharge to bill lag. How long is that taking? Why is that taking? Those types of things. Your coding productivity. We've already mentioned it. That goes hand in hand with, with AI, as well as your backlog for coding, your CDI coverage, and the impact of that. I think Nick already mentioned, but the case mix. What is your case mix? What is your cost per claim? Do you understand what your cost per claim is? Your cost per encounter. So I think all of those things can really play into what is it and what are the areas that I need to focus, because again, you're trying to figure out how you can prevent the denials downstream. And so by having that real-time information on a dashboard is incredibly helpful for you to make decisions.
And James, how are you thinking about it in terms of figuring out what needs to improve and then steps to improve those particular areas?
So if you sum up a lot of things that they're talking about, you look like at us. We have razor thin margins, cash flow. So if my DNFB, if my discharge not final bill, if everything going in, if I'm having denials that suddenly, I don't know, for lack of a better word, if the payers are weaponizing their AI system to deny me, and I'm not getting that out there, it's crushing our cash flow, and that has massive impacts on us. I don't want to dip in the piggy bank, to make payroll. So we have to go back and look at this, and that's one of the things that we came back is like just keeping those lights on and keeping that going through as fast as possible. So that's our prioritization, is getting that cash through here. Not only getting, to a degree, and it's a two-pronged. Absolutely want to get the most possible that we can for the work that we're doing, but also it has to be timely. Yeah. So I think Adar kind of commented on that a few times. It's like, it's not going to help me, if I'm adding 2 or 3 extra weeks to that workflow process because suddenly my denials have jumped up too much.
And
Very,
Anthony,
go ahead.
if I could just add real quick, I mean,
Yeah.
one of the things that we've really focused on at Providence is that that dashboard is data, but it has to have several components. It's got to be real time. Okay, having data from 2 days ago, 3 days ago, a week ago is not helpful at all. It's got to be automated. So you can't have people, a big team, running around trying to put together manual dashboards. And then to kind of the question or the comment you were getting at is that it's got to be operationally actionable. Great. So you have all this data, you have this wonderful dashboard. If it is not something that operations can take action on, what's the point? You're not hitting your goals. You're not getting to to the criticality of that data.
I must say that's spot on and
Yeah.
transparency. We're very transparent with our dashboards. Anybody in the organization can see them because they all need to understand it's a team fight, not an individual.
Nick, I just want you to follow up on that point because it's such a great point. This idea of being operationally actionable. Like one question you could ask someone who's showing you a dashboard they either want to build or they've built is, okay, what do you do based on this information? If they
Right.
don't have an answer for you, well, say it's nice to know. Some things are nice to know, but you want something that allows you to take subsequent steps to improve some of the metrics you're seeing.
Yeah, absolutely. I mean, it what decisions is this dashboard or is this information helping me to make, right? Like
Right.
that should be the optic through which we really look at these dashboards because yeah, there are a lot of things that you can make look pretty on a dashboard with all different graphs and colors and different things, but at the end of the day, that information needs to help me make a decision as quickly as possible, right? And gives me the information to see where are we trending, where are we heading if I don't make a difference now or I don't make a change now, what does that look like from a modeling standpoint in the future? I think that's another key piece of this as well. Is not just looking at historical information, but what is that historical information telling me about where we're headed, right? And I think that's an important piece of this as well.
Yeah, so I just wanna go over some stuff. Make sure we're being as practical as possible. I mean, on a high level, we've discussed the importance of this area to focus on some areas within this subject matter. You can look at the idea of creating dashboards. We talked about different job roles, trying to take up some of the low level stuff with AI. We know those tools are out there. You can partner, you can work with people. Again, I just want to be as practical as possible. So, if anybody has any specific questions in the audience, please let us know. But otherwise, are we missing anything, Nick, in terms of just high? Obviously, we can't get into specific individual customized uh, consulting services here for each person, but anything we're missing, Nick, on just giving people practical takeaways?
I mean, I think we're hitting the
Yeah.
key points on this at a high level, right? I think really I mean, organizations are all going to have their various struggles,
Mm-hmm.
right? And with certain things depending on their areas of focus. And I think really it's operationalizing a way for identifying where those challenges are and where what's the process the organization follows once that problem is identified to improve it, right? I think that's a key piece for everyone to take away.
Yeah, Otter, and maybe start with the examination of where you are and understand that if things aren't trending in the right direction, it could be this dynamic of payers turning on the AI, so to speak. Could be, you know, you.
Yeah.
I assume every healthcare organization is looking closely at these metrics, um, but we talked about margins and the need to improve 'em. Anything else you want to add, Otter? And then I'm going to go with our ask a co-panelist.
I think of my colleagues and I think we've given quite a bit
Yeah,
of impacts. No, I don't have much more to add to that.
James, anything else? Any other piece of advice before we do the around the horn?
Well, I think, like you said, if you don't think you can afford to do the AI, but from a rural health perspective, I think you better go back and revisit that conversation because I understand that you want to get that new MRI, but you're going to have a building to run it in. That's the way I look at this. I think it's
Wow.
that serious. So
That's really, really good advice. And I think, just that reorienting anyone's thinking. Um, is so important. So let's do our Ask a Co-panelist. Nick, I'm going to go with you first. Do you have a question for one or both of your co-panelists?
Yeah, I mean, I'll pose it to both James and Adar, but where are you guys seeing the most significant return on investment as it relates to AI implementation within your organizations?
Otter, let's start with you.
Okay. For me, it's a number of different areas at Providence. And so we're focusing a lot on, again, as I mentioned, the medical record has tremendous amounts of data, more and more every day. And so how do we summarize that information so that both clinical decisions can be made, but also when it comes to revenue cycle operations, how do we get that information to be able to automate that those processes? The second thing is again, I think it was already mentioned, but autonomous coding. I think there's some really easy, simple coding that can be done and be reviewed as opposed to having it be done manually. So looking for opportunities again to focus on where can we automate some of these tasks using AI so that we can free folks up to do other things. I can't remember if it was you, Nick, or James, or somebody said it very well when they said, look, it's going to be, the future is going to be about humans using AI. And here at Providence, that's been a real focus, is we are trying to take as many tools as we possibly can with AI and implementing them into the work stream. Not looking to replace people, it's looking to augment the work that they're doing. And so I would say that is probably our biggest and highest focus right now.
James, anything you want to add?
Yeah, I think, and this is coming from our perspective, so based upon our specific needs, but we really wanted to focus on the documentation integrity and the coding accuracy. Just doing that, getting rid of the manual CDI review and some of the manual coding, where we can use that for an assist. And we're kind of looking at those numbers right now and where it can bring some different technologies to bear. But just a 2% improvement in your case mix index has a huge return for us. And so we felt that was something that we could pursue, look at, prove our point, and that allows us to go into those next things that are coming up. It's those small measurable wins. We can't have go live dates and say, okay, now we got to start tracking this right out of the gate and start seeing the things that are in here. It's got to be dynamic. So we're having to change the way that we look at things a little bit, but then we'll go into automating charge capture and some reconciliation, but we've developed our own outline based upon our specific needs, where our strengths and weaknesses lie. But I think it's there, and get those small wins that'll start building up for the larger ones.
Excellent. James, do you have a question for one or both your co-panelists?
So I think the one thing for us is, we're always talking about how do we actualize on these. So how do we go from a project to products and get that in here? What's a good recommendation to sit there and say, okay, we're going to deploy AI, but I now need to make it reality. It's really one thing. We all go to trade shows and we say AI this, AI that. I want to talk about, do you have like some recommendations on how we reframe the mindset to take this from a project to a product?
Nick?
Yeah, that's a great question. I think that, as we think about projects end, right? Whereas products evolve. And so from my standpoint, it's really kind of looking at these RCM optimization as a product, ensuring that there's an owner, right? A product owner, a roadmap, KPIs associated with the product. And my background is healthcare software development, right? So I really see the product owner, that product manager, being the one to help in identifying the what. So your business interacting with the business stakeholders, really being clear on what are those workflows, where are their bottlenecks, and helping to identify the what that needs to be enhanced or improved or augmented with the technology, and then engaging with the IT teams to identify the how, because typically your more technical resources are natural problem solvers, right? That's why they've kind of gone into that domain. And so enabling them to figure out the technologies or how to leverage the technologies to solve that business problem is kind of the recipe for success in my mind.
Otter, anything you want to add?
Yeah, I mean, RCM is no longer just a series of disconnected projects. It's literally a living product ecosystem. So you've got to have dedicated cross-functional persistent teams. Persistent is the key. Shared roadmaps. So where are you going? What are we working on? There's got to be living, breathing documents, but just have an understanding of what the future is going to be looking at, and continuous iteration upon that. Not episodic changes, but iteration upon iteration as you deploy. Again, AI is still a lot of it is still unknown. So you've got to be able to iterate and make some changes. Real-time feedback loops, I think, again, are really critical here at Providence to make sure that we are getting the feedback that the stuff that we deploy, we're getting that feedback real time. Measurable outcomes we already mentioned, and then I think that a lot of people don't mention, but you got to reduce that technical debt because RCM behaves, like a product because it has, it has continuous ongoing users, it has continuous policy changes, and then multiple integration points. So treating as such leads to higher adoption, better quality, and then I would say more sustainable outcomes.
All right, very good. Otter, do you have a question for one or both of your
I
co-panelists?
do for both, and I'd be interested because it's going to be two different perspectives. But one of the biggest focuses here at Providence is really to reduce the burden for our clinicians. And so I'm curious for a lot of your RCM optimization efforts. How are you ensuring that you're clinically aligned, not just financially driven?
James?
So one of the things that we've talked about and have been approaching with ours is that real-time interaction with the system as they're doing their documentation and they're going through maybe a Medicare well visit. We kind of have those mapped out already, and it prompts them in testing. So far, we haven't deployed this. It prompts them when they're doing that. And one of the things that they like was they said that gave them a lot more data. We implementing a search and summarization, so they're seeing more meaningful data and not just a hurried chart prep that comes in, that they feel like they can actually approach the patient with the things that are going to help them get better. Because they may look at something and go, we're maintaining, but we're not getting any better. And that was one of the things that they felt was exciting, that they can see that in pretty much a darn near real-time interaction with the patient. Next step, and go back to what Nicholas said, the hope is that it will evolve as it comes in to start prompting them. We use an ethical AI component. It's not allowed to make any clinical decisions for us at all. We don't ask it to, nor does it. But we want to be prompt and have that data and ask them to come in here. So that's the one that we came in with, that aspect of making it better for the patient. And they've embraced that. And of course, by default, that gives us better documentation. In theory, gives us better coding and reimbursement. Patient-centric first.
Nick, anything you want to add?
Yeah, I mean, so again, my perspective is going to be a little bit different. Like you were saying, I think what I'm surprised to see is that how many organizations out there still either do not have a true CDI program implemented, or it's inadequately staffed, right? And so the approach that we take is really kind of starting in that retrospective view, kind of highlighting things we've already talked about, but really looking at what money's being left on the table, where is your documentation inadequate, and from a retrospective standpoint, being able to show putting a quantitative measure before the team to show them this is the upside potential that you have. And in instances where they don't have a program or don't have the resources, right, providing those services, the human capital to help with implementing a true CDI program. And the goal of which is always to kind of move more to the left, right? Making it, like James was saying, more real time, being able to have that review post-code, pre-bill, being able to catch that information before that claim is sent to the payer, right? Before that denial happens, because as we all know, that's the cost just escalates once the further down the process it goes. So that's how we're kind of working with our customers along that line.
Perfect. Thank you, Nick. All right, that's about all we had time today. Excellent conversation regarding continuing education. You can use the final slide in this deck. You'll get an email when the on-demand recording is ready for viewing. If you want to work with us, you can reach out to Nancy Wilcox from our team, and you can go to our website to register for upcoming panels. With that, I want to thank our wonderful panel, Otter Palace, James Wellman, and Nick Raup, and I want to thank E4Health for sponsoring today and making the event possible. And thanks to you for attending. And with that, everybody have a wonderful day. Thank you.
Thank you.
Bye.